Assalamu alaikum. The article for this week is titled with evaluation of factors affecting the association between thickening of sinus mucosa and the presence of periapical lesions using cone beam CT. It was done by Gurhan and his colleagues. They are Turkish group, published in International Endodontic Journal in 2020. Maxillary sinusitis of odontogenic origin is a sinus infection and symptoms caused by various dental pathosis. Several studies strongly supported a much higher prevalence of odontogenic maxillary sinusitis, up to 86%. Based on that, odontogenic infections are considered one of the major predisposing factors that initiate maxillary sinusitis. It's very important to diagnose the true etiology of maxillary sinusitis and differentiate maxillary sinusitis of endodontic origin from other odontogenic sources, since it's required the particular treatment. Maxillary sinusitis of endodontic origin is a new term used in recent literature. Sinus pathosis can be presented radiographically as an opacity in the sinus thickening of the basal mucosa or sinus polyp, and the most prominent radiographic finding reported for odontogenic maxillary sinusitis is basal mucosal thickening with a prevalence up to 90%. Since there are no published data evaluating endodontic lesions, various lesion parameters and association with the thickening of the sinus mucosa, considering both the amount and type of thickening. So the aim of this study was to evaluate the effect of various factors associated with periapical lesions on the amount and type of mucosal thickening using CBCT images. Good quality without artifact CBCT scans of 1,000 patients were obtained from January 2015 to January 2018 and examined retrospectively. Of 1,000 patients, 102 females and 100 males aged from 18 to 64 years were included in the study, and the primary inclusion criteria were the presence of first and second premolars and or molars with more than 2 mm mucosal thickening of the neighboring maxillary sinus. Any case of moderate or severe alveolar bone loss, a suspected intrabony lesion, and the presence of dental pathosis restoration or orthodontic retainers affecting the image quality of the premolar or molar region were excluded. And regarding the assessment of amount and type of mucosal thickening, the thickness of the mucosa was measured in millimeter using the coronal sections of CBCT scans at the point of maximum thickness from the sinus floor to the uppermost point of the thickened mucosa, and categorized according to Champag et al. In 2013 as a class 1 if it's 2.1 to 5 millimeter, class 2 if it's 5.1 to 10 millimeter, and class 3 if it's greater than 10 millimeter. For the type of mucosal thickening, it was classified as flat if it's horizontal thickening, or polypoid if it's dome-shaped thickening, according also to Champag et al. In 2013. Periapical lesion was assessed as a mucosal thickening, considered as a mucosal thickening associated with the periapical lesion if at least on maxillary posterior tooth and or had a radiolucency. Factors were evaluated are tooth type, either premolar or molar, number of teeth and number of roots associated with the periapical lesion, diameter of periapical lesion, and anatomic relationship between maxillary sinus and periapical lesion. Periapical lesion diameter were measured using the CBCT periapical index that described by Estrella et al. In 2008 as 0 up to 5, 0 if it's intact periapical bone structure, diameter of periapical radiolucency if it's greater 0.5 to 1 millimeter, it's considered to be 1, and 2 if the diameter of periapical radiolucency from 1.1 to 2 millimeter, and 3 if the diameter from 2.1 to 4 millimeter, and 4 if the diameter of periapical radiolucency from 4.1 to 8 millimeter, and 5 if it's greater than 8 millimeter. The distance between the uppermost border of the periapical lesion and maxillary sinus floor was evaluated and classified using a 3-graded scale as 1 if there is a distance between lesion and sinus floor, and 2 if the lesion is in contact with the sinus floor, and 3 if the lesion has penetrated the sinus floor. All measurements and evaluations were repeated twice with a 1-month interval. The mean of the 2 measurements was calculated and used for statistical analysis. The result showed that only 96, which is 48%, 96 cases of mucosal thickening were associated with periapical lesion, and the overall difference in the prevalence of mucosal thickening between the genders was not significant, and the most frequently amount of thickening detected was class 3 with 42%, and it was significantly greater amongst males compared to females. Flat type was the most frequently encountered type of mucosal thickening with 59%, and maxillary first molars were most associated with mucosal thickening, followed by maxillary second molars. A significant association with the amount of mucosal thickening were gender of the subject, number of roots and teeth, and periapical lesion diameter, but single factor was associated with the type of mucosal thickening, which is the number of roots with periapical lesion. As the number of roots associated with periapical lesion increased, the degree of mucosal thickening and the prevalence of polypoid type of thickening increased significantly. This study and these results concluded that the mucosal thickening of the maxillary sinus is strongly associated with the number of roots with periapical lesion and lesion diameter, and around 50% of all mucosal thickening cases was associated with periapical lesion. Therefore, dental and medical collaboration is necessary in order to prevent refractory maxillary sinusitis cases and improve the quality of life of these patients.